All right, everybody, here we go. And we are about to go ahead and start with a fantastic condition, probably one of the most common conditions you will see in the ankle and foot, which is an inversion ankle sprain. So you should know a sprain as a tear, educate your patients around that. Remember, our best outcomes are associated with education, empowerment, exercise, and then our manual therapies come out, right? So partial or complete tear of the lateral ligaments following forced inversion or inversion and plantar flexion is usually associated together. The inversion sprains may also strain the fibularis longus and brevis muscles, typically fibularis brevis, where it inserts onto the head of the fibula. So you also have to check for an avulsion fracture, not head of the fibula, where it inserts onto the base of the fifth metatarsal, pardon me, where you have to really check for an avulsion fracture at that location, more common with more severe inversion sprains. So super common injury. Almost everybody has had this, 45% approximately of all sports injuries. Generally, what do we see? Peak athletic years, male equals female, risk factors, prior ankle sprain. If you sprained it before, you're probably going to sprain it again. And I love seeing ankle sprains in my practice because I used to sprain my ankles all the time until I found the wonder of wobble boards and rocker boards, and then even basic yoga. Something as simple as doing a tree pose can improve proprioceptive ability. But we'll come back to this once we get into our treatment. So prior ankle sprain is the number one risk factor. What else? Athletic activities involving running, cutting, especially where you have cleated shoes, like in soccer and football, or strong surfaces that you get good grip on, like in basketball. Also, you want to evaluate landing technique. They may also be a supinator as well, which may predispose, or this pes cavus or high arch. Yes, if they have decreased proprioception, once they've sprained, they may sprain again. And then muscle imbalances, the peroneal muscles aren't very strong. I also strongly recommend walking barefoot on sand as well as a way to strengthen up these muscles, but we'll come back to that. So assessment, forceful trauma, twisting or rolling of the ankle. The person might actually hear a popping sound and likely have a prior ankle sprain. They'll fully understand this condition. They will limp after injury, the limp with swelling over the lateral. There may be inspection, there may be swelling over the lateral ankle. You do have the golden period before it actually puffs right up, but generally what you're going to see is swelling over the area of injury. So ATFL are the specific ligaments, so anterior talofibular, calcaneal fibular, and posterior talofibular. Possible bruising and ecchymosis, especially as it gets more severe. Palpation is tenderness over the ligaments, and that's the beauty of ankles. Unless it's really swollen, we can actually palpate most of the structures that are damaged. Compare bilaterally. In more severe cases, there will be an extreme limited range of motion and maybe even avulsion or damage to the fibularis muscles. Neurovascular should be within normal limits unless they have a more significant vascular rupture, but I had one case where a guy was running on some train tracks, and where the train tracks met into each other, their foot got caught and they kept going. And there was actually some significant vascular rupture in that case. So in which case it was worthwhile doing a more detailed pulse check and vascular exam. All right, inversion grading. Mild is going to be no bruising. And this is really how you're going to tell grade 1, grade 2, grade 3 are mild, moderate, and severe. Negative stress tests, so the ligaments are probably intact. This will heal relatively quickly. They might even have just the most mild limp, but hardly anything. Now you have bruising for the moderate, grade 2, bruising on one side. And this is a huge spectrum of injury right here. You can have an obvious limp. They won't be able to hop or run typically. This can take up to a couple of months to heal in the more higher end of this grading system. And then of course we have grade 3 or severe bruising, both sides of the ankle. You have to rule out a fracture. If you see a grade 3 or severe ankle sprain, you automatically should just be doing diagnostic imaging just to make sure you're not missing any fractures. They'll be unable to weight bear, complete loss of function. Likely they're going to come in and see you on crutches or some kind of wrap or support from a loved one who's bringing them in. And you are going to be looking at a functional recovery time of 1 to 3 months in this case, possibly even longer, up into that 6 months area, depending on what their healing factors are. Are they younger? Do they have good aerobic fitness, good diet? Those kind of things are going to make a huge difference. So differential diagnosis, number one, especially in more severe cases, has to be a fracture, whether it's that avulsion fracture of the fifth metatarsal, whether it is lateral medial malleoli, actual chip fractures or impact fractures, or you could be looking at a syndesmotic or high ankle sprain. That is what the grade 3 is, because it hits all 3 of the lower ligaments and then catches the tibio and the anterior and posterior tibiofibular ligaments, as opposed to the talofibular ligaments as well. I quite like these pictures. They're nice and simple, but walk you through it so you can understand it. What else do we see? Tendonitis of the Achilles tendon or peronei muscles. Again, usually palpatory tenderness, muscle weakness over top. Osteochondritis dissecans is a condition that comes up on your radar a little bit, but they may have osteochondritis dissecans in another location, like the knee, like the elbow as well. Not a super common one, but something that should be there. Special tests should be done carefully to start, where you can do a rotational stress test. Anterior and posterior drawers are great of the ankle. And why not even challenge into that inversion range of motion as part of your assessment? There are the Ottawa ankle rules, which are essentially the same as the basic fracture screen that I teach. So you can go onto YouTube and type in Vizniak fracture screen, or you can just remember, is this person over 55? Do they have a failed 4-step test? Do they have dark black bruising, history of significant trauma, exquisite point tenderness over the, what are we looking at? Navicular, cuboid, fifth metatarsal. Those are going to indicate more likelihood of fracture. Management is great. I love inversion ankle sprains because I've had so many myself. It's been fantastic to go through. So general measures, a lot of people will respond better to the ice if they are of the older generation. Current research may not support that quite as well. This is one place where when I was first in practice, I did some experimenting. And what I would do is I would try ice versus heat on acute ankle sprains. And almost to a person, people did not like the heat in an acute ankle sprain because already you've got effectively a compartment syndrome around that ankle. I put heat on it and it just feels like too much. So what are we going to do? Usually cold, or just let the body do its own process. And then eventually switching over to heat or meth, as the case might be, movement, exercise, traction, and heat. Consider short-term lace-up brace. These are excellent. And in fact, if they have a high boot, even a boot can work well for this. It doesn't have to be a separate lace brace unless they are trying to play their sport at the same time. Increased success may be, just wait. Note that long-term bracing does not show increased success and may slow normal recovery. You do not want to become reliant on the braces. Start performing your range of motion activity as soon as possible. The sooner I can get you weight bearing and moving, the better the outcomes are. And we know that for most conditions that we're dealing with. All right. If we are looking at massage therapy is an excellent choice, working on areas of compensation, other things around with the muscles that are tight. So any of your techniques are going to work there. Maybe to start with some manual lymphatic drainage, switching over to Swedish and relaxation techniques, all in the acute phase. Just get this person calmed down. And then subacute, now you can get into there for a little bit more stripping. I'm a big fan of instrument assisted techniques because I feel like every stroke is more efficient when I'm doing that. Chronic, you can be looking at proprioceptive, proprioceptive neuromuscular facilitation. You can also be looking at contract, relax, different movements. Joint mobilizations are going to be great for these people. IASTM again. And then osseous mobilizations that address ankle, knee, hip, low back, SI are going to offer benefit as well. Try not to force this person in directions of hypermobility and focus on moving them into areas of hypomobility with your mobilizations. Electrotherapeutics can help, especially ultrasound may offer some benefits, acupuncture. Medications, short-term NSAID use, maybe. You could consider prolotherapy if you have gone through and they have ligament laxity in a chronic case where all of your other, where all of your other conservative care pathways haven't worked for them. That might be a good idea. And very rarely, surgical interventions may be done as well for extremely unstable ankles, but this is a pretty stable joint generally. So getting in there for the surgery, usually not warranted, but in severe cases or chronic recurrent cases, this might be an idea for you to co-manage with an orthopedic surgeon. All right, rehab, pain-free range of motion, ice after activity potentially, later increasing range of motion. Consider a rocker board. In my clinics, what we do is we actually give patients rocker boards. Of course, we have our clinic name and everything stamped on them, so we get them back. To get them back on this rehab pathway into better balance and proprioception as they're moving through their wobble board and specific activities. And something as simple as this, standing on one foot at your countertop, can be enough to maintain balance where you can reach out with your hands and improve proprioceptive function. I am a big fan of this when I'm teaching a yoga class and we have people with some ankle sprains. I'll take extra time in tree pose to make sure they can develop good proprioceptive ability and move their body with the windy tree back and forth and all that good stuff. Prevention, modify activities that cause pain or swelling. Consider orthotics or postural evaluation if there is an underlying supination type issue, and address technique issues in jumping, running, landing, stopping, pivoting. All of those can be risk factors that we can actually influence. Prognosis is excellent in mild cases. Early rehab is key. Get them moving, educate, empower, and graded exercise exposure. Moderate to severe injuries may take a little bit longer and may have more significant outcomes for lifestyle. And try and eliminate or minimize the development of chronic issues here by doing the appropriate rehab. Realize that if you have had a lot of chronic inversion ankle sprains, you may develop osteoarthritis or DJD of these joints later on in life. So that would be a good example of us walking through an inversion ankle sprain. Absolutely fantastic condition. We can do a lot for our patients. Remember, know your anatomy, detailed assessment, education, once you get the correct diagnosis, education, exercise, empowerment, and our manual therapies are all going to be wins for these patients. All right. Thank you very much for your time, and we will see you on the next video.